Unlock the future of pathology with Pathology News, your ultimate source for cutting-edge insights, expert analysis, and the latest breakthroughs in digital and computational pathology. Don't just stay informed, stay ahead.
Hello and welcome to Pathology News. Today we're discussing the use of AI for image analysis in pathology. Now, we've seen this field come on dramatically in the last few years, but we're only now starting to question if the algorithms we've developed for diagnostics and research are really testing for what they say they do on the tin. Here to break this down with me is Dr. Minhas, the Associate Professor of PRISM. That's the Predictive Systems in Biomedicine Lab, and that's centered at the University of Warwick within their computational pathology group. Fayyaz has also been the author or co-author of a recent study that explores this topic. Fayyaz, welcome to Pathology News.
Thank you for having me, Sidney. It's a pleasure.
Yeah, and lovely to have you here. Fayyaz, I hope you could start by introducing yourself and the aims of the study.
Thank you. So my name is Fayyaz. You already mentioned that, and I'm a computer scientist originally. I have had training in bioinformatics and machine learning in bioinformatics, and since moving to Warwick in 2019, I've been working on computational pathology as part of the Tissue Image Analytics Center. And ever since we started working on this, we've seen this field grow so much. And as a scientist, one of the questions that we've always had is what are the limits of these machine learning methods that we are developing? And one theme that kept recurring was, are these machine learning methods predicting what we think they are predicting, which led to the aims of this study, which were to essentially analyze what are the causal factors underpinning the prediction from a machine learning model when we use these models to predict biomolecular features or biomolecular statuses from whole slide images.
Great. And, having read your study, you mentioned shortcut learning in there. Now, I was hoping you could, maybe give us a definition and why that's so critical to the study.
So shortcut learning is a phenomena in machine learning where if you're trying to predict something and you've got a certain label, let's say you want to predict whether there is a cow in a given image or not, and you train your machine learning model to predict it from images of or scenes where there may be cows in some scenes and there may not be cows in another scene. Then if you train it on a data set where cows are in grassy fields, and then you test it on images of cows in, say, standing on a beach, then the model, because it would have picked up the correlation of cows being in grassy fields only, will not be able to predict that whenever that scene changes. So it's essentially picking up. So shortcut learning, the formal definition is to use correlations rather than actual causations with the label to predict something, and that is quite common or can happen in machine learning. So we just have to be careful about it.
Yeah, absolutely. Interesting. So I understand that confounding factors play a part in this. So to use your analogy, the confounding factors would be the grass in the analogy. Could you tell us a little bit more about confounding factors and why they're so critical to shortcut learning?
So every time we train any machine learning model, what we try to do is to predict something of interest. That's what we want. But the observations that we have, they can be confounded by, or they can have associations with other factors, which just turn up in the data itself, but are not causes of the label that we have. In the cow analogy, for example, it's actually the presence of the cow itself as the animal that is the actual signal that we want to detect. But everything else, like the grass, for example, or if there are, for example, there are fences in there, or the sky, if there are those factors that are consistently associated with this label, but are not causing the label itself, then everything like that becomes a confounding factor that we need to guard against. So age in a clinical study, for example, risk when we try to predict cancer recurrence, for example, or the severity of cancer or survival rates from cancer, and age or gender can also come up with as confounding factors, which do help us in a way of identifying how long someone is going to survive, but really doesn't tell us something deeply about the tumor in a way.
Yeah. I think it's fair to say that the stakes are a lot larger when we're talking about a patient's cancer diagnosis in comparison with looking at an image of a cow in a field. That's when confounding factors become really serious business. Now you mentioned, or sorry, in the study you highlighted a case study for this being BRAF mutations. Just to set the context a little further, could you go into depth on that for us?
Yeah. So what we noticed is, so a lot of these machine learning methods that are coming out, they're trying to predict the mutation status of different genes. For example, BRAF, or they can
Hmm.
predict the mutation status of TP53 or another gene for that matter, right?
Hmm.
What we asked ourselves is it really the only effect that these models are predicting, is it only that one particular mutation or not, right? So when we say that a model, when using a whole slide image as input, is predicting whether a patient is BRAF mutant or not, then is it really that only that mutation that it is picking up? Because in biology, these mutations don't occur in isolation. So these mutations can co-occur with other mutations, kind of like the cow co-occurring with grass most of the time, but it can occur without that as well. So in order to test that, what we found is that when you develop a machine learning model to predict, let's say, BRAF mutation, then it is significantly confounded by the mutation status of all other genes as well. So as a matter of fact, if you take overall tumor mutation burden of everything other than TP50 or BRAF and try to predict that, the same model can actually predict that as well. So it is not just the effect of BRAF mutations that it is predicting, but the combined effect of all mutations, even the ones that don't involve
Okay.
BRAF. So the signal that the machine learning model is utilizing to predict BRAF is not
Mhm.
specific to BRAF.
Yes, yeah. And obviously, when these algorithms are put together, they're tested there and then, and we understand that that's not perhaps a true clinical environment. So, what happens when they do enter a true clinical environment?
I think it's so if the goal is prediction only, so when we're just
Mhm.
trying to predict and you benchmark it on a large enough set of the right population and it's giving you very good results, it's okay. But it's essentially when you want to mine what signal in the tumor or in the tumor image is it picking up that it's using to predict. That's where the line becomes a bit blurry. So it's when we
Mhm.
want to infer what is the cause of this prediction, then what we find is that it's not identifying the correct cause. So the model isn't learning
Mhm.
just that specific component associated with that mutation, but a whole bunch of other things. So what we are saying is, unlike the existing tests that are currently being done in the clinic, the molecular tests, where if you test for BRAF mutations, then those molecular tests only tell you the status of BRAF mutation, nothing else.
Mhm.
That's very specific. In comparison, when we use these image-based tests, then what if a test says that it is identifying something as a BRAF mutant or a patient as a BRAF
Mhm.
mutant, then it may not only be that mutation, and maybe at times that mutation may not exist, and it may just be the effect of other mutations which are leading to the label. So these are not as specific, but at the same time, so the short answer is essentially that the method is not very specific or very precise in the signal that it's picking up in comparison to
Mhm.
existing tests, and that just needs to be kept in mind. The other thing is, it doesn't mean that these tests or these image-based predictors are useless in such scenarios. They can
Mhm.
still help you. If, for example, if you want to triage who should we test with a molecular test, then these tests can still be used, but with only with a very large validation set before they're put into clinical use. So
Mhm.
what we propose in the paper is that biologists and everyone, all the stakeholders working with such tests, they need to understand very clearly that such limitations due to confounding factors and biases exist before you put them into a proper use case.
And to expand on that, you've identified this in perhaps a few cases, but do you think this is something that's happening en masse with a lot of AI algorithms in clinical practice and in research and beyond?
I believe so. What we started off with is actually benchmarking our own tools, the tools that we developed. So the most of the work that we presented, because we didn't want to blame anyone else before we looked at our own tools. So we had started analysis of our own tools developed in our lab of whether they were working right or not. And what we found is that yes, they had these biases, and so they were giving very good prediction results. So they were giving state of the art predictive performance, but then we identified that they have these biases, and then we expanded them to tools developed by other people in the lab for. And I must commend them for putting those tools and their architecture out in the open for us to be able to test. So I think that is a very good thing for the field. It helps us validate these methods. So when we validated those, we found similar signatures or the similar type of confounding and biasing in those models as well. And I believe the problem isn't coming from the design of those machine learning methods. Well, partly it is from that, but partly it is because the data sets that we actually use to train these methods have such confounding factors to begin with. So it's not that the design of the computer science or the machine learning tool is bad in any way. It is because the data that we use has those confoundings. And then we as computer scientists, when we develop those tools, we don't compensate for that in their design.
Yeah, great. And I think it's so important that algorithm developers have that kind of transparency. We are all in this together at the very early stages of using AI in healthcare, and we won't be able to move forward unless we work together, identify issues like this, and try and fix them together, right? Um, Next question for you then. You also compared AI performance with simple clinical features like tumor grade. Were you surprised to see the advantage of deep learning was relatively modest?
I just want to make that statement a bit more precise, if I may. So, what we found is in the study that in certain cases where pathologists aren't really trained to predict someone's mutation status, but what they can do is assign grade, for example. And what we wondered is, what if we just use grade as a proxy for tumor status? Perhaps
Mhm.
people with certain type of mutations would always have higher grades. So what we found is that sometimes these pathologists assigned categories like grade or stage, those are actually very strongly related to the the status of these mutations or other gene expression patterns.
Mhm.
And what the conclusion was that over and above that, how much does AI and machine learning add? And in certain cases, what we found is that it's not a whole lot, which was quite surprising. So in one case that I am remembering off the top of my head, if we just use grade, then the sort of AUROC or accuracy that we get for predicting a certain mutation was around 75%. And we can go up to 78 or 79% if you use the state-of-the-art machine learning method to predict that mutation. So the gain beyond what a pathologist can in principle do is relatively modest. But for other genes and other mutations, it was actually much larger as well in certain cases.
Yeah, that's really interesting, isn't it? I mean, I think, half of us look at AI as being something that will perhaps replace pathologists one day, as it gets better and better. And, we approach super intelligence rather than artificial intelligence, which is, in theory, going to be here in a few years. And the other half of us, are, I think quite rightly so, are a little bit pessimistic. Pessimistic. There's a few hurdles that we have to get over that perhaps we can't see just yet, in terms of deploying AI clinically anyway, and successfully.
That's very beautifully stated. I think of myself as a realist in that regard. I'm very excited by the potential of AI. And at the same time, I think we need to identify what works and what doesn't. And we need to be very clear in terms of testing, pushing the limits of these methods. So every time you get a prediction, always ask the question, is it really what we think it's predicting? Yeah.
I want to move this on to a spatial conversation now, and specifically the tumor microenvironment. Now, we've seen that the spatial context of a tumor microenvironment is becoming more and more important. And with the amount of information that we can farm there and get out to support diagnosis and diagnostics. So I suppose to counter the argument of the study, really. But do you not think that although the construct validity might have been proven to be poor, but actually this information, the the spatial location of cells between each other, all provides data that contributes to this signal, that's also incredibly important and would be valuable in a patient's diagnosis.
If there's one thing I've learned while working in computational pathology is context, 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 and location, location, location. It's essentially where am I and what's around me as a cell that is actually determining what the outcome of the patient is going to be. And as you very well put, that is the tumor microenvironment. In the context of our work, what this means is that if we've got different mutations going on, so what classical example I give is if you've got an object and let's say that it's an object that we cannot see, kind of like Plato's allegory of the cave, where we can see shadows of the object, but we can't see the object itself, right? And what we are trying to do is to infer by looking at what the shadow looks like, and we try to infer something as to what the object would look like. So what we observe in the image in the tumor microenvironment is a manifestation of different actors like mutations and all the biological pathways that are casting their shadow in the image. And what we see is a mix of all of those different biological processes. And what the paper shows is that our machine learning methods are picking up something spatially or in the tumor microenvironment, but it may not be specific to a single pathway where you expect it to be associated with a single pathway. So in the context of, for example, our BRAF mutation, is it only the BRAF mutation that is causing these type of changes in the tumor microenvironment? Or is it a collection of other processes as well that is leading to this? And our conclusion is that these methods can very correctly identify the combined effect of different processes, but are not specific enough to be able to infer the effect of individual factors in the tumor microenvironment.
Yeah, and fantastically well answered, actually. Thank you. If these models then are relying on correlations rather than true biology, what risks does that create when deploying AI in real clinical settings?
I think the biggest risk is not coming from the method itself. It's coming from the human who are going to use it to make a decision. If they're not sure about the limitations, or don't realize that it can give you an answer just relying on these correlation structures, then we'll not be able to find cows when they're standing in front of us, but on a beach. And that might, for example, in cases where there are outliers, if we make a decision on that basis, that is going to be a problem. So what the message in the paper is that it's okay to use these methods for prediction, benchmark them, but also make sure that you do realize these limitations before making a decision for a patient. The other aspect is essentially in the design of these methods itself. I think the life cycle of how these methods are developed needs to change a little bit. We need to not start off with just the data. Computer scientists and pathologists and oncologists, they need to sit together in order to identify what are actually the causal structures or the causal factors that would be affecting a prediction, and what are the confounding factors. So when we develop these methods, we are able to know how to design them better, but also know their limitations before we use them in clinical practice. So the risk essentially is improper development that we've shown in our paper. It gives rise to these confounding factors.
Yeah. And in terms of, obviously you mentioned the development there and perhaps the evaluation as well, but how should we be looking to change our approach to developing AI with all of this in mind?
The first question is, pathologists, having worked with them, they're very good in terms of understanding the overall causal structure. So what would give rise to this type of tumor microenvironment? with oncologists as at the same time. Computer scientists like me, I believe we, first of all, need to work with oncologists and pathologists to be able to understand those causal structures better. So it's kind of like that multidisciplinary integration needs to be more robust. We need to be able to understand each other's language. And that does require some education programs. So at the Tissue Image Analytics Center, we've recently launched our biomedical AI program, which is open to doctors as well. So we can create a community to work very closely with each other to understand what is actually the clinical question, what are the causal factors in that. And that should be the first step before we even start talking about collecting data. Because let me give you a simple example. If we think that gender or, for example, age or ethnicity is going to be a major factor in a certain prediction problem, then we need to first understand that. And then when we collect the data, we need to collect these variables so we can benchmark against them. We can modulate in our machine learning model design. And the next stage, of course, is when we do the testing part. That also needs to be done extremely carefully on a very diverse population, where we expect these correlations to exist, but also in other populations where these correlations may not exist. So we just need to make sure that that testing is done in a purely multidisciplinary manner involving all stakeholders who've developed the algorithms as well as independent assessors. So that is the key life cycle. In terms of publications, I believe the mindset around publications also needs to change. Rather than going for whoever is giving us the highest AUROC number, we also need to see, are they really predicting what they say they are predicting, and but what proof have they presented over and above these numbers in order to give us more confidence. So when we tested it, we developed some new solutions to take out these confounding factors. What we noticed is that your predictive performance always drops. It's a surprising thing, but then your model isn't comparable and thus may never get published. So it's kind of like a number of things, starting with data collection, understanding the problem, testing, and then even publication. All of that, you just need to be a bit more present. We need to think of these confounding factors when making those decisions as well.
Yeah, that's really interesting, and that really brings us right back round. We started talking about us being on the cusp of using AI in healthcare, and in this session we flagged a few things there that could change in order for us to develop AI with a higher validity construct. Are we really testing for what we think we are here, and make that the norm rather than having bias in there built into it. If there's anything that clinicians and researchers could take away from your study, then other than what we've spoken about there, would you have anything to add to that?
I think that the field has grown significantly, and I've been keeping a tracker of where we are. I believe I've identified a few things where we need to work more closely, I believe. And one of them is developing multidisciplinary research programs where people can come together and be more open in terms of discussing these confounding factors. The same thing is more openness around data, more openness in terms of methods, so we can do this type of testing, which requires people to come in with their data sets and people to come in with their methods, so we can do this type of analysis and testing to identify these confounding factors. The only question I think of is, would I like to be tested with one of these methods that I'm developing or not, right? And I think that puts me right where we should be in terms of having patient-centric deliverables. And I believe as long as we keep that in mind, everything downstream of that is going to be very, very much aligned.
Yeah, I think you've hit the nail on the head there. Almost putting ourselves in the patient's shoes when we think about the development of this AI. And one point that you mentioned today about bringing biologists and computational scientists together, so they've got an equivalent understanding of what we are trying to look for, is really critical to us moving forward with this. Well, I think we'll call it a day there. thank you so much for joining us today. I think it's been a really insightful discussion, and I'm looking forward to sharing it with our readership.
Thanks so much, Sydney. It's been a pleasure.
Thank you, and goodbye to our audience.
Thank you. Bye.